Welcome everyone to RTI International's COVID-19 webinar series. We're so glad you could join us today. I'm Dr. Pia MacDonald, an infectious disease epidemiologist here at RTI. I'll be kicking off this session today on perceived threat of COVID-19 and introducing our speakers. First, I'd like to tell you a little bit about the webinar series and the research we'll be sharing. We have planned 4 webinars, each on Wednesday in the month of May, on different topics related to COVID-19. The data come from 2 RTI-funded national surveys of the American public. Last week's topic was knowledge. Next week will be our last webinar on the series, and we'll be sharing insights from the national survey about vaccines, including people's intention and behaviors related to them. Please join us for that session. We anticipate that the presentation today will be about 25 to 30 minutes, and we'll spend about 10 minutes at the end of the presentation for questions. We're fortunate to have an interdisciplinary team across RTI working on a range of COVID-19 issues, including the work you'll hear about today. I'd like to acknowledge the full team working on this survey. Representing that team today are 2 presenters, Dr. Jessica DeFrank and Alicia Frasier. Dr. DeFrank is a health communication research scientist with over 20 years of public health experience. Her expertise includes the study of patient perceptions and decision-making in a variety of contexts, including cancer and prescription drugs. She also studies best practices for communicating scientific uncertainty to lay audiences. Alicia Frasier is a survey director and an expert in the execution of multiple methods for survey research. In her 17 years of experience, she has used many different methods to collect data on topics ranging from children to medical examiners. Dr. Linda Squires will serve as the moderator for the question and answer portion of the webinar. If you have questions for one of our speakers, please submit your questions in the Q&A on Zoom. If you have a technical questions about using Zoom, you can use the chat feature and Patrick will be available to help. After each of the webinars, we'll email you the slides. I'll now turn it over to Alicia Frasier to tell us about today's presentation.
Thanks, Pia. Today we will share findings related to these questions. How do Americans perceive the threat of COVID-19 to themselves and others? Have perceptions of threat shifted over time, that is, over the time period between the 2 waves of this survey? Are threat perceptions linked to engaging in COVID-19 related behaviors? And what are the implications for these findings? Related to the topic of threat, we will also explore the public's perception of risk and worry about the disease. To collect these data, we used Ipsos's Knowledge Panel, a probability-based internet panel designed to be representative of US households. This panel uses an address-based sampling approach to recruit and maintain the panel. RTI developed the survey instrument and conducted the analysis of the resulting data. We conducted 2 waves of data collection with different respondents, and these data allowed us to look at changes over time. The first survey was fielded the last week of February, and the second survey was fielded in mid-April. The data from both waves were weighted to represent the US population. We collected data from just over 1,000 respondents in Wave 1 and approximately 2,300 respondents in Wave 2. Our online survey included items on perceptions of risk, threat, and worry. We also assessed the public's knowledge about COVID-19 as well as their attitudes and beliefs around mitigation behaviors and whether they were practicing them. The questionnaire is designed for the core items to be repeated over time, which allows us to look at changes and trends. In the second wave, we added or adapted items to assess emerging issues with COVID as they arise. We also gave respondents the opportunity to tell us in their own words about their motivations for practicing COVID-related behaviors, and we will share a few examples of these quotes in today's talk. On this slide, you can see the characteristics of our survey respondents. These numbers are weighted to represent the characteristics of the US population for several factors, including gender, age, race, and ethnicity. While this slide shows data for the second wave of the survey, the demographics from the first wave were similar. Both surveys include a diverse group of respondents. This includes diversity by education level, which is something that some online research does not always address. In the bottom right corner, you can see that more than a third of our sample are individuals with a high school education or less. We also had representation for all regions of the country and oversampled individuals with Hispanic ethnicity in wave 2. We compiled this timeline to provide context for these data and to remind us all what was happening when. The tall green bars on this table represent when RTI collected data. On the left, you can see that our first wave occurred right before a state of emergency was declared and before COVID-19 had begun to make a significant impact on the US. In fact, the first death from COVID-19 in the US was reported over the weekend that the Wave 1 survey was in the field. The tall green bars on the right-hand side show when we collected our second wave of data in mid-April. In the 7 weeks between the two waves, you can see the number of states declaring states of emergency in the blue bars. The green bars show the number of states declaring stay-at-home orders, and the red bars represent the issuance of face covering requirements. Amid all of this is the national emergency that was declared March 13th, the social distancing order from CDC that was declared March 30th, and the face covering order that was declared April 3rd. We conducted the Wave 2 data collection within about a week of CDC updating its guidance about using cloth face coverings when out in public, and after most states issued stay-at-home mandates. So now I'll hand it over to Dr. DeFrank to provide a little background for today's topic.
Okay, thank you, Alicia. So one of the goals of our talk today is to demonstrate what the social and behavioral sciences can offer in managing this epidemic. So as everybody on this webinar already knows, COVID represents a massive global public health crisis. And while efforts are underway to develop a vaccine and treatment for this disease, we must manage this crisis through large-scale behavior change to slow the spread of the virus and mitigate its return. These behaviors include hand washing, social distancing, wearing face coverings, to name a few. While some of these behaviors, such as hand washing, are fairly simple to do, other behaviors may place a rather significant burden on many individuals, and they may not practice them either consistently or at all. So understanding the underlying psychological factors, such as the public's perception of threat and risk, can provide valuable insight for addressing this disease. So before sharing our findings, I want to spend just a little time explaining our key terms, as this understanding will provide some helpful context when we turn to the data later. And this part may feel a little bit like graduate school, but bear with me, we'll move quickly. So our survey measured perceived threat with a series of items that read, what level of threat do you think coronavirus poses to either yourself and family, or to other vulnerable populations, including healthcare workers, the elderly, and those with serious health conditions? When people perceive the threat of a situation, they are making a mental evaluation of both the severity of a disease and their vulnerability or susceptibility to disease. In other words, perceived threat is a measure of how bad is it, and will I or others get it? So as we turn to the data, you can think of perceived threat as a more encompassing evaluation of the situation. Perceived risk, which is also referred to as perceived susceptibility, is part of perceived threat that I just showed. Here it refers to one's belief about their chances or likelihood of getting coronavirus. And worry, our other key measure, is the continuous thinking or rumination about an impending negative event, which may or may not happen. So whereas perceived risk is more of a mental calculation, worry is more of an emotional response. And somebody may perceive themselves to be at risk, but won't worry, and vice versa. We also know that not everybody will perceive the threat of COVID the same way. And knowing how certain groups differ in their perceptions can guide us towards a more focused communication approach. Today, we will look at some of the more interesting subgroup differences by age, race and ethnicity, education, U.S. region, and whether respondents had any conditions that, according to CDC, put them at higher risk for severe illness or hospitalization. So, how do Americans perceive the threat of COVID? And we'll now turn to our data. Okay, so this slide shows how respondents perceive the threat of COVID to various vulnerable populations, including the elderly, those with compromised immune systems, those with serious health conditions, and healthcare workers, and also to themselves and their families. The red bars represent the proportion of respondents who perceive COVID as high or very high threat. The blue is moderate, and the purple as low or very low. And as you can see, the majority of Americans perceive COVID as a serious threat to vulnerable populations, as shown by the set of graphs on the left, whereas they perceive the threat as more moderate or even low when thinking about themselves or their families, as shown on the graph on the right. So drilling down on this finding a little deeper, we wanted to know if perceptions of threat to the self or family differed by subgroups, which we will show over the next few slides. These bars represent the proportion of respondents who perceive COVID as either a high or very high threat to themselves or families, and the red bars show where we have statistically significant subgroup differences. So as you can see on the right, non-whites, Hispanics, and those with less than a high school education perceived COVID as a greater threat to themselves or families compared to their counterparts. And while our survey cannot fully answer the question as to why these groups perceive a greater threat, there could be several possible explanations, including their type of work outside the home or access to healthcare, to name a few. We were somewhat surprised to see that older Americans did not differ from other age groups in their perception of threat to themselves or family, as shown by the bars on the left. We can offer a few possible explanations for this finding. First, it is possible that older adults might minimize their feelings of threat as a coping mechanism. But another likely explanation is that older adults are doing the behaviors they are supposed to do, like not leaving the home and physically distancing themselves when they do. So they perceive their threat as more moderate on account of doing the recommended behaviors. We also looked at our findings by risk group for severe illness. So about 1/2 of our sample reported one or more of the following conditions that, according to CDC, place them at a higher risk for severe complications due to COVID. And notably, only 22% of our sample was over the age of 65, indicating that people of all age groups were at risk for potential serious complication. As you can see by the set of bars on the bottom, those who were at higher risk for serious illness, as shown by the red bar, were somewhat more likely to perceive COVID as a high threat to themselves or family, a difference of about 8 percentage points. Yet, as shown on the bars at the top, a sizable proportion of those at high risk for serious disease, 27%, describe the threat to themselves or families as low or very low. And as I spoke to earlier, this finding could be because high-risk populations are taking this disease seriously and engaging in protective behaviors, so they perceive their threat more moderately. But yet another explanation is the potential for optimism bias. Optimism bias is when people feel that they are less likely to be affected by a serious event compared to others. Optimism bias has been shown across a variety of disease contexts, including cancer. So it's fair to say that people perceive threat in a variety of ways. And as one respondent put it, at my age, 85, I have too many other medical problems and am too old to have this problem visit me, which suggests that messages about the risks associated with older age and existing health problems are reaching the public. As I noted at the top of the presentation, we also looked at measures of perceived risk and worry, which I will cover just briefly in the next few slides. As you can see, a majority of our sample do not think that they are likely to get COVID, with 72% saying they either disagree or strongly disagree with this statement. And although we don't have time to walk through all of the data here today, the findings were largely similar to what we saw before, with certain race groups, Hispanics, and lower education groups perceiving their personal risk as higher than their counterparts. And while a majority do not think they will get COVID, a fair amount worry about getting it. And this worry was higher for those living in the Northeast, which makes sense given the high prevalence of disease, especially in New York and New Jersey at the time that this survey was fielded. So is worry a good or a bad thing? Well, we know from research that a healthy amount of worry can be a good thing and can motivate a variety of protective behaviors. And we'll turn back to this topic a little later. So now Alicia will discuss how perceptions have shifted over time.
So as mentioned previously, we conducted 2 waves of data collection with different samples. As a result, we are able to assess how public perceptions changed over time from early on in the pandemic to shortly after the CDC issued recommendations for social distancing and wearing cloth face coverings. To measure change, we asked many of the same questions about threat, risk, and worry in both waves and compared the mean scores. Our analyses controlled for a variety of variables, among them gender, age, education, and income. As we would expect, the perceptions of threat to self and family and vulnerable populations increased over the approximately 7 weeks between our waves of data collection. The time between our waves of data included declarations of states of emergency, issuance of stay-at-home orders and face covering recommendations, as well as the significant increase in number of COVID-19 cases and deaths in the US. As such, we would expect to see increases in perceptions of personal risk and worry about getting the coronavirus, and you can see those increases here. Although the increase for perceived risk might not be as big an increase as one might expect given the events between wave 1 and wave 2. Using the responses to our open-end question, what is your main motivation to follow the strategies in your state or community to try to slow down transmission of the coronavirus? We could see that the public health messaging was clearly being received by some of our respondents. For example, respondents told us, "I don't want to put anyone in harm's way and affect their health, especially with the increasing death rates right now. And we don't want our family to get sick, especially since some are older and might not make it if they get sick." Implied in these statements are sentiments about the growing seriousness of the disease and sentiments about the well-being of others, not just oneself. The next step in our examination of threat, risk, and worry led us to looking at what, if any, influence these had on implementation of mitigation behaviors. To get at this question, we looked at whether respondents said they were practicing the 12 behaviors listed here, which included hand washing, social distancing, not inviting friends and family into the home, and wearing cloth face coverings. We created an index of the total number of behaviors practiced by each person. This is a nice way to capture a lot of information about implementation of behaviors in one snapshot. This graph shows the average number of behaviors practiced across increasing perceptions of threat. On average, wave 2 respondents were practicing between 6 and 7 of the 12 behaviors. And as shown by the upward sloping lines, the higher the threat that people perceive COVID-19 to be to themselves or their family or others, the more mitigation behaviors they indicated practicing. And similar to before, the higher people perceive their personal risk for disease and the more they worry about it, the more behaviors they indicated practicing. These findings are encouraging and suggest that shifting those at the low end of the spectrum to more moderate levels of threat, risk, or worry can give us the desired effects on practicing behaviors. Although on average, these increases translate to about 1 to 2 additional behaviors, this can make a difference when applied across the population, especially when it is a behavior like hand washing or social distancing. Finally, we looked at which individual behaviors are most or least affected by shifting people's perceptions of threat. These data points show the proportion of people who said they were practicing these 5 behaviors. As you can see from the top blue line, over 90% of people are already practicing hand washing, but we see some modest changes in this behavior as threat perception increases. Yet a shift in threat perceptions resulted in rather dramatic changes for behaviors such as social distancing and wearing cloth face coverings. You can see for a couple of the behaviors like not letting people into the household or wearing cloth face coverings, the largest shift happens between very low threat to moderate threat. The increase between moderate and very high is not as pronounced. This indicates that focusing attention on those with very low and low perceptions of threat might result in the biggest gains. So we've learned that shifting people's perceptions of threat can influence their behavior, but health behavior theory tells us that's just one piece of the larger puzzle. In order for perceptions of threat to motivate behavior, 2 other things should happen. Those are highlighted here in yellow. First, people need to perceive a response to a threat as effective. In other words, will this behavior work? Second, people also need to have confidence in their abilities to perform a behavior, which we refer to as perceived efficacy. Having both of these coupled with a level of perceived threat help lead to behavior adoption. To address the question of perceived efficacy, our survey asked respondents how effective they thought each of the following behaviors would be in slowing down the spread of coronavirus. Around 85% of the sample perceived these key behaviors to be effective, with the exception of wearing cloth face coverings, which was substantially lower. Although this may be a result of the timing of our second wave of data collection, which came days after the first face covering recommendation was issued. Looking at the perceived efficacy of all of these behaviors on the slide, we see that just over 1 in 10 people likely question the effectiveness of these key behaviors. So there's room for improvement here, but a majority perceive these as being effective, contributing to the theory we discussed on the previous slide. Perceiving a threat and perceiving effectiveness of the suggested behaviors leads to a higher adoption of these behaviors. We did briefly explore the topic of self-efficacy in our survey, asking whether respondents felt confident about sheltering in place or success in getting people in their household to stay at home. The majority of respondents did feel confident that they could shelter in place or stay at home for however long authorities recommended, at about 86%. But that leaves 14% who don't feel confident about that behavior. In addition, 22% felt it was hard to get people in their household to stay at home. Again, a majority felt they could, but these are decent sized proportions who are not feeling confident in adhering to some of the recommendations. Lacking that confidence can lead people not to adopt suggested behaviors. So now I'll pass it back to Jessica to discuss what we do with all of this information.
So thank you. So what does this all mean and how do we move forward from here? So we recently came across this excellent perspective piece where the authors concluded that communication strategies must strike a balance between breaking through optimism bias without inducing excessive feelings of anxiety and dread. So the goal is finding that sweet spot and clearly communicating risk and threat in a way that is helpful, but does not have the unintended effect of causing dread and fear. Other strategies can be applied to communication and practice are, first, emphasize the effectiveness of performing preventive behaviors. And if the effectiveness is unknown, then it is better to state that uncertainty. Practitioners or even employers can help by instilling confidence in people's abilities to perform the recommended behaviors. This can be done by modeling the behavior and sharing stories or strategies for overcoming barriers. Messages should explain how performing these behaviors not only benefit the individual, but how they also benefit other people. And it also may be wise to emphasize the importance of performing several of the behaviors available to us rather than just focusing on one. And a final tip, especially for states, are to consider developing focused messages for vulnerable or priority populations. Although we want our messages to resonate with everyone, we know that communication campaigns can be more effective when they focus their message content to specific populations. And it's critical to do this in ways that consider the education and cultural makeup of the population. And I'll end today by emphasizing the importance of testing public health messages with your audience before they are disseminated. And that's something we do a lot of here at RTI. We know that a message that works for you or us as communicators may not necessarily work for our audience. And finally, a lot has changed in the month since the last wave of data collection in April. Since that time, many states have begun the process of reopening their economies, and people are eager to return to normal. So practicing social distancing and other behaviors will remain important as we move into this next phase. Yet it is unknown how this changing landscape will influence people's perceptions and willingness to perform these behaviors. So continuing to monitor many of these behavioral outcomes will remain important. And we hope for an opportunity to do that.
Great. Thank you so much for your presentation, Alicia and Jessica. I'm Linda Squires. I'm a senior health communication scientist at RTI, and I'm going to moderate our question and answer session this afternoon. We're going to spend about 10 to 15 minutes answering questions that have come through the question and answer feature in Zoom. And I've been answering many of your questions as both Jessica and Alicia have been presenting. So you can see my contact information as well as Dr. Lauren McCormack, who is our Vice President for our Public Health Research Division at RTI. So you can reach out to us directly after the presentation if you have any questions, or we're definitely looking for organizations who are interested in partnering to continue our survey efforts going forward. So I'm going to go ahead and kick off our questions and answers. The very first one is, if respondents who did not perceive a significant threat from COVID-19 had a strong basis for that belief, how can we use communication to change strongly held beliefs? I'll toss that out to the group.
That's an interesting question. Yes, of course, we do have high-risk populations and those that are considered at lower risk. So they may be at a personal lower risk for the disease. But of course, this disease is so highly contagious and can spread without any symptoms that I think the message that we needed to get out there and largely have is that regardless of your own personal risk status, the possibility exists that, being in contact with others could spread an asymptomatic disease that you're carrying. So I think that the message there is that there is a benefit to others that you must consider.
Great, thank you. I know we've had several questions, which I did actually type a response into this question, about whether or not people, whether we asked respondents about their own personal experience with COVID. And so let me just answer that verbally too, though, because I know there's been several questions on that. We did ask people whether or not they had symptoms of coronavirus, like if they had cough, fever, shortness of breath, and if they had tried to get tested but were unable to, whether they received a positive coronavirus test, if they received a negative coronavirus test, if they'd been hospitalized for coronavirus, and if they had recovered from the coronavirus. So we asked that question of the respondents. We also asked that same series for if they had had someone in their household other than themselves who'd had any of those events, shall we call them, and also whether or not they'd had anyone in their household that had died from coronavirus. We also asked if they had a friend, coworker, or family member not living in their household who had any of those events as well. So we're able to certainly take a look at segments or segment respondents by whether or not they'd had symptoms themselves, etc. Okay, so the next question is also about, are we able to further segment the racial, ethnic, and age groups surveyed even further than the data that we presented? Would someone on the team like to answer that question?
Sure. I believe that we are not able to segment too much further, maybe on race and ethnicity. We'd have to look again at our age categories, but I believe that we received a lot of the data in those categories themselves. And I think as a team, we've felt for the most part, those are good groupings for looking at the data, especially by age, because it gives us that look of, you know, what we've heard in the media, where young people maybe aren't taking this as seriously, old people are more at risk, are they taking it more or less seriously? So I think for the most part, we've felt that the categories that we have by age, race, and ethnicity have been sufficient for what we wanted to examine.
Okay, here's another one I'll toss to the group. Do you believe the public will become more relaxed about protective health measures, hand washing, social distancing, et cetera, as COVID-19 eventually fades from the media coverage public awareness? Rather, as perceived threat fades, do you expect associated protective health behaviors to fade? How can we persuade the public to continue beneficial health behaviors? Great question.
Great question. And we would love to be able to answer that question. And as I alluded to at the end of the presentation, you know, a lot is changing right now with states reopening their economies, people are beginning to get out a little more. But right now, it is still critically important to practice these behaviors. So even though COVID is still out there, the threat is still out there, it's possible that people are perceiving that threat is less. And we would love to be able to examine that in another wave of data collection. So would love to partner with anybody out there on that.
Okay, so what role do you think fear plays when it comes to various states opening up communities and economies?
Linda, could you repeat the question? What role
do you think fear plays when it comes to various states opening up communities and economies? So there's several questions that are really not so much about our findings, but really asking you to project. What do you think the future is going to look like now that the states are and communities are opening up? And that, you know, I think this opening up really signals that, you know, things are going to go back to normal, or the threat, I think people are going to perceive that the threat is perhaps less than it was during shutdown. So I think our audience is interested in the panel's viewpoints on what do you think is going to happen in terms of threat, and how do we message around that?
I'll just jump in. This is Alicia. I think one of the things that's going on here is that there is potentially still, you know, in regards to the state's decisions, a knowledge of threat or fear, if you will, about the disease itself. But I do think there's a conflicting interest here about threat or fear of economic consequences. And to me, so this is me speaking personally, to me, that's my perception that there is a fair amount going on here, that tug of war is occurring between which fear or threat is winning out. And so, I think states are thinking about trying to balance that when public health officials might be indicating that the threat of the virus is still very real and should be paid attention to.
So this is Pia MacDonald speaking from an epidemiological perspective. And what the shutdown did was buy us time to prepare individuals, organizations, communities, and others to do the social distancing that needs to continue to keep the transmission low within our communities. So to be clear, it's very important for us to maintain the social distancing aspects and go about our business as best we can, minimizing our individual and collective risk. Thank you.
And I'll just add to that. This is Dr. Lauren McCormack. The response may vary by the experience in a particular community, and when we know that those experiences have been different. The fear can sometimes be a motivator for some individuals, and then for others, it can have an opposite effect. So there are other factors that you really need to look at and how they work together to influence people's behavior and what's going to help them make decisions.
Great. So we have several questions that ask about whether or not we have information about people's access to masks and other protective measures and how that impacted behavior. I can try to answer this one. We did ask several open-ended questions that asked about people's most pressing questions and what kinds of challenges that they were facing, and access to the cloth face coverings definitely came up. So we did not, we also asked about their confidence and their ability to practice these social distancing behaviors. We have a series of questions around that, and whether they could keep people in their household safe and themselves safe. And we ask about their own behaviors as well. So we do ask about whether or not they had been wearing face coverings and whether or not they intended to wear face coverings when they were to go out. We have to keep in mind when we collected data, this was mid-April, and we were right in the middle of pretty much everybody being in lockdown, shall we call it. So, in that kind of circumstance, people had different needs in terms and abilities, I guess, or opportunities to practice many of these different behaviors, social distancing behaviors. People that just stayed in their house didn't really need to be going out and wearing face coverings if everybody else was staying in their house as well. So we also asked about their intentions to wear face coverings. So we've got data from this second wave of the survey that is really around these behaviors and around intention to wear face coverings, because we knew that was a recommendation that had just been made by CDC right before we were going into the field. So we did expect to see that there would be a difference between what people had been doing, and then because the face covering had not necessarily been recommended at that point, and then what they intended to do. So we do have data on that. We also, just as a reminder, in case you might have missed this part of the presentation, we did do a survey that was at the end of February and the first couple of days of March, way before any mitigation strategies had been put into effect, way before they were even being talked about in the media. So we can look at some differences in behaviors over time. So that's that's something that we've done in several of the presentations, both the first webinar where we looked at the social distancing and face coverings, and in the knowledge as well. And then today we did look at some of those differences just in the perceived threat. We do tend to look at all of these variables together in a big model. That is one of our plans going forward. In addition to paying attention to cultural and individual contexts, what are specific strategies to communicate threat to those who perceive very low threat? Anyone want to take that question?
Sure, I'll jump in. I'm sure Lauren will have thoughts on this as we work on this quite a bit. So there are a few strategies for communicating risk, and there are actually in books and chapters written on this. One thing is, and this is going to sound basic, but it's clear communication and using plain language. You know, if you're using too much medical jargon to explain risk, you lose people. So you need to just break this down to very plain language. Numbers help. People want to see numbers. So sometimes that's not always available, but just to say, you know, your risk is rare is not helpful enough to people, because people can interpret the word, for example, rare in a lot of different ways. So by rare, do you mean, you know, about 1 in a million or 1 in a 1,000? So we don't have that answer here all the time, but to the extent that we can provide some numbers to let people just have a sense of what that looks like, that could be helpful. And then making sure that your communications are sensitive to the education level of your audience. We try to typically write to a 6th grade education level. So again, this gets back to the plain language piece. Yeah, so those are some of the key strategies we use, but again, there are a lot of other tips in there as well.
Yeah, and I'll jump in and just say this. It's really important that we do take a look. You know, I've got several questions here that are also asking about how we think perceived threat and severity to be changing moving forward. And you know, I do think that, you know, opening things up, people's perceptions of the threat is going to be really different. It's a huge signal that you know, the threat is less, because now lots of things are opening up, and it is a challenge to make sure that people still understand that just because there are openings, that the threat is still very real, and we need to be monitoring over time what people are believing and thinking and perceiving in terms of threat, and in terms of their behaviors, their protective behaviors. You know, we see lots on the news, but are those just the, you know, extremes, or is that really what most people are doing? So having surveys like this, I think, is really important, and also using other data collection strategies to find, well, to test out messages, because if we are finding, oh, well, perceived threat is really going down, we need to continue to develop messages so that people understand that, well, that's not actually the case. The threat hasn't lessened necessarily. And so when we craft messages, they can't just be factual. You know, we really need to be focusing on and not just the threat, but also the motivation. So we have to couple knowledge, the threat, and then motivational messages to keep practicing protective behaviors all together into an overall messaging strategy. And we need to test those messages before they go out, because they may resonate differently and motivate different groups differently. So, you know, with emerging infectious diseases like this and other emergencies, it's oftentimes hard to do that, as to, you know, everybody's trying to get the facts out as fast as possible. But we have time and luxury here to actually do testing. The testing can be very quick. We can do it in lots of different ways, and we'd be happy to partner with you all. We have a whole Center for Communication Science at RTI, where this is what we do day in and day out, and we're experts in crafting messages, testing messages, refining them, and then putting them in products, campaigns, and finding ways to reach even really challenging and difficult, hard to reach populations, to make sure they're getting the information, and not just the facts, but like I said, the motivational messages and messages about threat and severity and susceptibility as well.
And I'll just add one other thing to that, the importance of communicating, particularly from credible sources, as with prior public health education campaigns have done, like in the areas of HIV and tobacco, helping to minimize confusion that could help people have information that they need about the accuracy of the science and the information as it's evolving, because this is something that is evolving and will continue to do that.
Okay, I'm going to end with a really great question, and it's open up to everybody. What communication strategies can be used when we live in a social media ecosystem that is rife with misinformation?
That's a great question. We even have, I believe, one of the experts on misinformation attending this call today.
Brian, if you're on, feel free to.
Yeah, feel free to jump in.
Hi there, everybody. But yeah, go ahead.
Put you on the spot.
With us, Dr. Brian Southwell, who just happens to be an expert in misinformation.
Well, I'll offer just a 30-second comment that part of what we need to do is really just think about being empathetic towards other people as we're all kind of making our way through this together. We've been writing and thinking about that quite a bit. There is a lot you can do if you Google our information. Been trying to think through strategies for helping us. It's a really keen insight that you raised, and it's a key problem of the moment, and it's going to be with us for a while. So we are working on that as well. So yeah.
Yeah, there are no easy answers on how to correct misinformation, and like Brian alluded to, it's something we hope to continue examining here at RTI.
Great. And I won't keep you all longer. We do like to stop before the top of the hour. I know we're all probably exhausted from all the Zoom calls we attend, and we like to give people a little bit of a break. I do want to let you know that we are, really would love to continue our survey efforts and are definitely looking for some organizational partners to help support those efforts. And not only that, but we have lots of other kinds of expertise that can support COVID responses. We have a slide up here that shows you that, many of the folks on the phone today come from our Center for Communication Science, our Public Health Research Division, and our Survey Research Division. We have lots of expertise across RTI. We've got epidemiologists and all kinds of other innovation data scientists and innovators to help support responses. So please feel free to reach out. When you exit today, please do take a moment, really 30 seconds, to complete our short survey. And it asks about your perceptions of the webinars. And if you have any outstanding questions, you can also leave them for us there. And if you would like one of us to contact you, one of us from the research team, to contact you directly, we are very happy to do that. So please, thank you again for attending, and I hope you all have a wonderful afternoon.